Welcome back to the deep dive. Some topics are foundational, and then there are the ones that are just mission critical, the kind of knowledge that can really determine an outcome in a matter of minutes.
Absolutely. And today we're strapping on our virtual scrubs and diving headfirst into one of the most vital, high-stakes areas of clinical practice: maternity, labor, and birth.
And we're looking at this through a very specific lens, aren't we?
We are. Our source material today is this incredible review text that's focused entirely on preparing for the NCLEX-RN examination.
And we have to give a huge thank you for that.
Oh, definitely. A huge and sincere thank you to Dr. Abdulkareem for providing this foundational and truly crucial source material for our deep dive today.
So our mission isn't just to, read off definitions. It's to really internalize the clinical judgment that the NCLEX demands.
That's the key. The exam isn't just about recall. It tests prioritization. It asks you to make the decision that, saves a life or prevents a serious complication.
Right. It's about what you do first.
Exactly. And when you boil down this entire complex process of labor and delivery, there are two concepts that stand above everything else. They are the non-negotiable physiological priorities.
And our source flags these right at the beginning.
It does. It all comes down to oxygenation and perfusion for both the birthing client and the fetus.
So if you, the listener, just keep those two words, oxygenation and perfusion, right at the front of your mind.
It makes everything so much clearer. The ABCs of life support.
So any question on the NCLEX about a problem, the answer is almost always the action that immediately helps blood flow or oxygen.
That's the shortcut. And we're going to use that principle to unlock everything today, from the basics of labor to the most dangerous fetal heart rate patterns.
Okay, let's get started. So let's build this from the ground up. The famous 4Ps framework. I feel like this is the first thing everyone learns.
It really is. It's that classic mnemonic that defines the four big interdependent factors. They all have to work together for labor to progress.
Powers, passageway, passenger, and psyche.
Right. And the NCLEX loves to ask questions where one of these Ps is having issue. So let's start with powers.
The dynamic force.
That's a good way to put it. We're talking about the involuntary uterine contractions, the force that's actually working to expel the fetus.
And these contractions have two really critical jobs in the first stage of labor. Can you break down how the cervix actually changes?
Sure. So the first job is effacement. You have to think of the cervix starting out thick and long, and it needs to shorten and thin out.
We measure that in percentages, right? From 0 to 100%.
Exactly. 0% is thick, 100% is paper thin. It has to thin out before it can really start opening effectively.
And that opening is the second job, which is dilation.
Right, the widening of the cervical os. And that's measured in centimeters, from closed all the way up to the full 10 centimeters needed for birth.
It's important to remember, though, that powers isn't just the involuntary stuff.
That's a great point. Once the cervix hits 10 centimeters, in the second stage of labor, the powers also include the client's voluntary pushing efforts.
And if those two things aren't coordinated,
then labor stalls.
Yeah.
You get maternal fatigue, you can get fetal compromise. That coordination is absolutely essential.
Okay, so the second P is the passageway. This is the physical route the baby has to take.
Right, and it's made of two parts. First, the rigid bony pelvis. This is fixed, and its shape can make a huge difference. A gynecoid pelvis is ideal, but other shapes can make it a much tougher journey.
And what's the other part?
The soft tissues. So the cervix itself, the pelvic floor muscles, the vagina, all the parts that can stretch and adapt.
Okay, next up is the passenger. This is where so much of the NCLEX vocabulary lives.
Oh, for sure. The passenger is the fetus, of course, but also the membranes and the placenta. And we have to assess it based on how well it's going to fit through that passageway.
Which brings us to attitude, lie, and presentation.
Exactly.
And let's not skip the last P, the psyche. It feels less tangible, but it's so important.
It really is. I mean, intense anxiety or fear can release stress hormones like catecholamines.
And those can actually interfere with labor.
They can inhibit the powers. They can literally slow down or weaken uterine contractions. So nursing care that supports the psyche, giving information, providing comfort, that is a direct physiological intervention.
You're actually helping the powers do their job better.
Precisely.
Okay, let's dive deeper into those passenger characteristics, starting with attitude.
Right. So attitude is just the relationship of the fetal body parts to each other. The ideal, normal attitude is what we call flexion.
All curled up.
All curled up. The back is rounded, chin is tucked to the chest, arms and legs are folded in tight.
And why is that so important for the NCLEX to test? What's the clinical significance?
It's all about physics. By tucking its head, the fetus presents the smallest possible diameter of its head to the pelvis. If the head is extended even a little, it presents a much larger diameter.
And that can stop labor cold.
It absolutely can. It's the difference between fitting and not fitting.
Okay, next up is lie.
Lie is simpler. It's just the relationship of the baby's spine to the mother's spine.
So most of the time they're parallel.
Right. We call that a longitudinal or vertical lie. The two spines are parallel. This will result in either a head-first or a bottom-first presentation.
But the other option, the transverse lie, is an immediate red flag.
A huge red flag. A transverse or horizontal lie means the baby's spine is at a right angle to the mother's. It's lying sideways.
And a baby can't be born sideways.
No, the presenting part will be the shoulder, which can't navigate the pelvis. So a transverse lie basically means you're preparing for a cesarean section. It's a high-risk situation.
Okay, that leads right into presentation. What part is coming out first?
Exactly. And overwhelmingly, it's cephalic or head first, like 95% of the time. This is what you want. The head is the biggest part, so once that's through, the rest usually follows pretty easily.
And then you have breech,
which is bottom first or feet first. There are a few different types, but they all carry higher risks, like cord prolapse. Many end up being delivered by C-section for safety.
Okay, now for the two metrics nurses use constantly to communicate progress: position and station. Let's start with position.
Okay, so position is that three-letter code you hear all the time, like LOA. It describes exactly where the baby's presenting part is in relation to the mother's pelvis.
Let's break down LOA, left occipito-anterior.
So the first letter, L, means the landmark on the baby is pointed toward the left side of the mom's pelvis.
The O in the middle.
O is for occiput, the back of the baby's head. So we know it's a head-first presentation.
Isn't the A at the end?
A is for anterior. The back of the baby's head is facing the front of the mom's pelvis. And ROA or LOA are the best positions for delivery. They just fit the best.
So those three letters tell you so much about how labor is likely to go?
A huge amount. But the single most objective, commonly tested measurement is station.
Station measures descent. How far down is the baby?
Exactly. And it's measured in centimeters relative to a very specific landmark in the pelvis. The ischial spines.
This is a huge memory hook for anyone listening. The ischial spines are station 0. What does that mean clinically?
Station 0 means engagement. The widest part of the baby's head has officially passed through the pelvic inlet. It's locked in.
What about the numbers, the pluses and minuses?
It's simple. If the baby is still above the ischial spines, it's a minus station, like -3, -2. The higher the minus, the higher the baby.
And if it's below?
It's a plus station, +1, +2. Once you're at +4 or +5, you can see the baby's head. Delivery is right there.
Yeah.
Understanding station is absolutely crucial for tracking progress.
All right, let's shift gears now to a skill the NCLEX loves to test, which is discrimination. The nurse has to be able to tell the difference between real labor and, well, not so real labor.
Yes, distinguishing true labor from false labor. This is a huge responsibility. You don't want to send someone home who's actually in labor, but you also don't want to admit someone who isn't.
So let's talk about the definite signs of true labor. What are we looking for?
The key word is progression. The contractions have to be progressive.
Meaning they get stronger over time.
Stronger, they last longer, and they get closer together. They don't just go away. They build. That's the hallmark.
And the absolute undeniable proof, the thing happening internally.
It's cervical change. True labor causes progressive cervical dilation and effacement. If the cervix is changing, it's the real deal. End of story. The fetus is descending.
Okay, so how does that compare to false labor?
With false labor, the contractions are irregular. There's no real pattern, and they don't progress. They might feel strong for a bit, but they don't cause any real cervical change.
And where are they usually felt?
Often high up in the abdomen or in the groin area. Not necessarily in the back, like true labor often is.
What's the one practical tip you can give a client to help them tell the difference?
Activity. That's the easiest differentiator.
How so?
True labor contractions usually don't stop if you walk around. Sometimes they even get stronger. But false labor contractions, like Braxton Hicks, will often ease up or go away completely if you change positions, walk, or even just take a warm bath.
So if moving makes them stop, it was likely false labor.
Exactly. It's a great triage question.
Okay, before true labor really kicks into high gear, the body gives some clues, right? pre-labor signs.
It does. There's lightening or dropping when the fetus settles down into the pelvis. First-time moms might notice they can suddenly breathe a little easier.
But they probably feel more pressure down below.
For sure. You also see an increase in Braxton Hicks contractions, maybe some more vaginal discharge.
And then there's the nesting impulse.
Yes, that sudden burst of energy to clean and organize everything, usually a day or two before labor starts. It's a real phenomenon. And sometimes a small weight loss, like 1 to 3 pounds, from fluid shifts.
All right, so once we've confirmed it's true labor, the baby starts this really complex journey down. Let's talk about the mechanisms of labor.
This is the series of twists and turns the fetus has to make to get through the bony pelvis. It's like a little dance.
And it starts with engagement.
Right, which we just defined. The head reaching station 0, locked and loaded.
Followed by descent.
Which is continuous. The baby is always moving down all the way through labor. We track that with station.
Then we have flexion.
As the head descends, it hits resistance from the pelvic floor, and that naturally causes it to tuck its chin to its chest. This presents that smaller head diameter we talked about.
Okay, now for the really critical movement, internal rotation.
This is pure geometry. The baby's head usually enters the pelvis sideways, but the outlet of the pelvis is widest from front to back.
So the head has to rotate.
It has to rotate to fit. Usually, the back of the head, the occiput, rotates to the front under the pubic bone. If this rotation doesn't happen, the baby gets stuck.
Once that rotation is done, what's next?
Extension. As the head comes under the pubic bone, it has to extend or tilt backward to actually emerge. The head is born by extending.
And as soon as the head is out, we see restitution.
Yep. The head immediately turns back to line up with the shoulders, which are still inside. It's an untwisting motion.
Followed by external rotation.
Which is when the shoulders rotate to fit through the pelvis, and you see the head rotate again on the outside.
And finally, expulsion.
The birth of the rest of the body. And understanding this whole sequence lets the nurse know if things are progressing normally or if there's a problem at one of these specific steps. It's a clinical roadmap.
And now we've arrived at the section that is, I think, the most high stakes. The part that generates the most clinical judgment questions on the exam.
Fetal monitoring.
Okay.
Without a doubt. This is where we are directly applying those core principles of oxygenation and perfusion. The fetal heart rate tracing is our window into how the baby is doing.
So let's start with the basics. Baseline, FHR, and variability.
Okay, so the baseline is the average heart rate between contractions. For a term fetus, that magic number you have to know is 110 to 160 beats per minute.
Anything outside of that range for a long period is a problem.
For 10 minutes or more, yes. Bradycardia below 110 or tachycardia above 160 means you start your interventions. Position change, oxygen, call the provider.
Okay, now, variability. This seems to be the single most important indicator.
It is. Variability is the fluctuation in that baseline heart rate. It looked like a jagged, squiggly line, and that's exactly what you want to see.
Why is that?
Because it tells you the baby's central nervous system is intact, responsive, and well oxygenated. A healthy, awake baby has good variability.
And we categorize it. Moderate variability is the goal, right?
Yes, the gold standard, 6 to 25 beats per minute of fluctuation. It's strongly reassuring.
But the NCLEX is going to test the concerning patterns, like absent or minimal variability.
Right. Absent is flatline, no fluctuation. Minimal is 5 beats per minute or less. Both of those are non-reassuring.
And the reason they're non-reassuring is?
The most dangerous cause is fetal hypoxemia or acidosis. The baby's not getting enough oxygen.
But there's a key distinction to make, isn't there?
There is. A baby can have temporary minimal variability if it's in a sleep cycle.
Which usually doesn't last long.
Less than 30 minutes. So if you see minimal variability, your first action isn't panic. It's to try and stimulate the fetus, maybe with a little sound or gentle palpation to see if it wakes up. If that minimal or absent variability persists, then you move to your priority interventions.
Okay, now for the good news on the monitor strip. Accelerations.
Yes. Accelerations are great. They're these brief, temporary increases in the heart rate. At least 15 beats up for at least 15 seconds.
And they usually happen with movement.
Right. It's a sign the baby is awake, responsive, and has adequate oxygen reserves. It's a sign of fetal well-being.
So the NCLEX strategy here is key. If you see accelerations, what's the correct nursing action?
Often it's to do nothing to document it.
Yeah.
You know the reassuring pattern, you can tell the client their baby is doing great, and you avoid any unnecessary interventions.
All right, now for the decelerations, the drops in heart rate. This is where timing is absolutely everything.
Everything. You have to know the difference between early, late, and variable decelerations. And it all comes down to their timing and their cause.
Okay, let's start with early decelerations. What's the cause?
Fetal head compression.
And what do they look like on the strip?
They're a perfect mirror image of the contraction. The heart rate starts to drop as the contraction begins. It hits its lowest point at the peak of the contraction, and it's back to baseline by the time the contraction is over.
And what's the intervention?
Nothing. You just document it. It's benign. It's actually a sign of progress, that the head is descending.
Okay, now, for the first really bad one, late decelerations. What's the cause here?
Uteroplacental insufficiency. The placenta is not doing its job.
And the look is different. There's a lag.
There's a critical time lag. The deceleration begins after the contraction has already started, and it doesn't recover back to baseline until after the contraction is over.
Why is that lag so significant?
Because it shows the baby can't handle the stress of the contraction. A healthy baby bounces right back. But if the placenta is compromised, the baby runs out of oxygen during the squeeze, and the heart rate drops as a delayed response. It's a clear sign of fetal distress.
And it requires immediate action.
Immediate.
Finally, the most common type, variable decelerations. What's the cause?
Umbilical cord compression.
And these look totally different.
Completely. They're variable in shape.
Mm-hmm.
Sharp, abrupt drops that look like a V or a W. And they can happen at any time, not necessarily with a contraction.
So if we identify a non-reassuring pattern, like a late or a severe variable, there's a sequence of priority interventions. What's step number one?
If the client is on oxytocin, the very first thing you do is stop the oxytocin.
Why?
Because oxytocin is making the contractions stronger and closer together, which is worsening the stress on the baby. Stopping it is the fastest way to give the baby a break.
Okay, step one, stop the pit. What's step two?
Change the client's position and get them off their back and onto their side. Left side is classic, but either side works. This takes the pressure off the major blood vessels and can immediately improve blood flow to the placenta.
Step three.
Administer oxygen, a non-rebreather mask at 8 to 10 liters per minute. This floods the mother system with oxygen to maximize what can get to the baby.
And then?
Increase IV fluids, especially if there's hypotension, and then notify the provider. You tell them what you saw, what you did, and what the result was.
Is there anything specific for those variable decelerations, the cord compression ones?
Yes. The provider might order an amnio infusion.
What's that?
We instill warm saline back into the uterus through a catheter. The goal is to create a fluid cushion around the umbilical cord to relieve the compression.
That makes perfect sense. You identify the cause compression, and the intervention directly fixes it.
That's clinical judgment in a nutshell.
All right, let's pull all of this together and walk through the actual stages of labor, focusing on the specific nursing care for each phase.
Sounds good. So stage 1 is the stage of dilation and effacement. It starts with true labor and ends when the cervix is fully dilated at 10 centimeters. And we break this stage down into 3 phases.
Let's start with the first and usually longest one, the latent phase.
This is from 1 to 4 centimeters dilation. Contractions are still pretty mild and far apart. The client is often excited, talkative, and can cope really well.
So what's the nurse's main role here?
It's a lot of education, comfort, and preparation. We encourage them to walk around, stay hydrated with ice chips or clear fluids, and very importantly, encourage them to void every 1 to 2 hours.
Why is that so important?
A full bladder can actually get in the way of the baby's head descending. It's a simple physical obstruction. So keeping it empty is a really simple but effective nursing intervention.
Okay, then we move into the active phase, 4 to 7 centimeters. Things are getting more serious now.
Definitely. Contractions are moderate to strong every 3 to 5 minutes. The client's focus shifts inward. They're less talkative, more focused on getting through each contraction.
And our care shifts, too.
Yes, now we're into active support. We're helping with breathing patterns, keeping the environment calm and quiet, maybe doing some back rubs or applying counter pressure.
This is also when pain medication or an epidural might be requested.
Exactly. Our job is to facilitate that, to make sure they feel in control of their pain management plan.
And then comes the transition phase, 8 to 10 centimeters.
The shortest, but by far the most intense phase. Contractions are powerful, very close together, and can last up to 90 seconds.
And the client's mood can change dramatically here.
Oh, yeah. They're often tired, restless, irritable. This is when you hear, "I can't do this anymore," which is actually a great sign that they're almost there.
What's the nursing priority during transition?
Support, support, support. You have to encourage them to rest completely in the short window between contractions. You might even have to wake them up when the next one starts so they can begin their breathing pattern.
So once we hit 10 centimeters, we're in stage 2, expulsion of the fetus, the pushing stage.
Right, and it ends with the birth of the baby. The client will usually feel this intense, overwhelming urge to bear down. That's called the Ferguson reflex.
And how are we tracking progress in stage 2?
It's all about descent. We're looking for that station to change. Going from, say, +1 to +2 to +3, that's how we know pushing is effective. We're also checking vitals and the FHR every 5 minutes.
Pushing is hard work. What is the most important physiological need for the client during this stage?
Rest between contractions. It's crucial. Pushing takes an incredible amount of energy. If they don't rest, they get exhausted, and it also compromises blood flow to the baby. So we encourage a few good pushes with the contraction and then total rest.
Okay, baby is out. Now we're in stage 3, placental expulsion.
This usually takes anywhere from 5 to 30 minutes. You'll see signs like a gush of blood and the umbilical cord getting longer as the placenta detaches.
The source mentions the Schultz and Duncan mechanisms. Is that important?
Not clinically, no. It just describes which side of the placenta comes out first. The priority is making sure the entire placenta is delivered and that it's intact.
And as soon as the placenta is out, what's our focus?
The fundus. The top of the uterus. It needs to be firm, like a grapefruit, and right around the level of the umbilicus. A boggy, soft uterus is a sign of uterine atony and a major risk for hemorrhage.
Which means immediate fundal massage.
Immediate and vigorous.
Finally, stage 4, recovery. The first few hours after birth.
Right, the first 1 to 4 hours. We're focused on physiological stabilization. Vitals should be returning to normal. The fundus needs to stay firm.
And the monitoring is intense.
Very intense. Vitals every 15 minutes for the first hour, then every 30 for the second. We're checking the fundus, the amount of bleeding, applying ice packs to the perineum, and of course, helping with that initial bonding and breastfeeding. It's a busy time.
Okay, for our final section, let's talk about some of the procedural interventions and anesthesia safety. These are high-risk scenarios where the nurse's assessment is critical.
Absolutely. Let's start with induction of labor. Before we can even start an induction, we have to know if the cervix is ready.
And for that, we use the Bishop score.
Right. The Bishop score looks at 5 things: dilation, effacement, consistency of the cervix, its position, and the baby's station. You get a score for each.
And why does the nurse need to know this score?
It predicts success. And there's a magic number to remember. A score of 8 or greater means you have a favorable cervix and a high chance of a successful vaginal delivery with induction.
And if the score is low,
then the cervix isn't ready. And you'll likely need to use cervical ripening agents first before you can even think about starting something like oxytocin.
Okay, speaking of oxytocin, it's a high-alert medication. What is the #1 safety rule?
Continuous monitoring. You have to watch the fetal heart rate and the contraction pattern like a hawk.
And what's the pattern you're aiming for?
A good, strong pattern. Contractions every 2 to 3 minutes, lasting about 60 seconds.
And when do you have to immediately turn it off?
If the uterus becomes hypertonic, meaning the contractions are too close, less than 2 minutes apart, or they last too long, more than 90 seconds.
Or if you see fetal distress.
Absolutely. Any non-reassuring pattern like late decelerations, you stop the oxytocin immediately. That's always step 1.
Okay, what about amniotomy, artificially breaking the water?
There's one crucial prerequisite for this. The baby must be engaged. Station 0 or a plus station.
Why is that so important?
Because if the head is still high up and floating, when you break the water, the gush of fluid can bring the umbilical cord down with it.
A prolapsed cord.
Which is an immediate catastrophic emergency.
So, because of that risk, what is the single most important non-negotiable nursing action right after an amniotomy?
You assess the fetal heart rate immediately. Your eyes go straight to the monitor. You're looking for a sudden, deep deceleration, which would signal the cord has prolapsed.
You're also looking at the fluid itself.
Right. Is it clear? Or is it meconium stained, which can be a sign of fetal distress? Is it bloody? Does it have a bad odor suggesting infection?
Okay, let's switch to anesthesia. Epidurals and spinals. What's the most common complication?
Hypotension. A sudden drop in blood pressure.
Why does that happen?
Because the anesthetic causes the blood vessels in the lower body to dilate. Blood pools there, so less blood returns to the heart, cardiac output drops, and blood pressure falls.
Which means less blood flow to the placenta.
And that's a huge problem for the baby.
So what's the key nursing intervention to prevent this?
Well, we give a big bolus of IV fluids beforehand to increase blood volume. But the most important thing is positioning.
We have to prevent maternal supine hypotensive syndrome.
Exactly. Never let a pregnant client lie flat on their back. We keep them on their side, or if they have to be supine, like for a C-section, we place a wedge or a rolled blanket under their right hip.
And that pushes the uterus off the vena cava.
Right. It keeps that major vein open, maintains blood return to the heart, and keeps the placenta perfused. It's a critical safety measure.
Okay, finally, let's touch on delivery procedures. For a cesarean section, what are the post-op priorities?
You're still monitoring the fundus and bleeding, just like a vaginal birth, but now you're also preventing post-surgical complications.
Like pneumonia or blood clots?
Exactly. So you're encouraging deep breathing, coughing, and getting them up and walking as soon as possible. And you're watching for signs of infection, like endometritis.
And what if it's an assisted delivery with a vacuum or forceps? Your assessment focus shifts.
It shifts entirely to the neonate. For a vacuum delivery, you're monitoring the baby for any signs of cerebral trauma, and you're looking for a cephalometoma.
A collection of blood under the scalp.
Right. And you have to be able to tell the difference between that and caput succedium.
Which is just normal swelling.
Exactly. Caput is just edema. It crosses suture lines, and it goes away in about a day.
Yeah.
A cephalometoma is lead. It does not cross suture lines, and it needs to be watched closely. Knowing that difference is pure clinical judgment.
And that concludes our really intensive deep dive into the essentials of labor and delivery for the NCLEX. We've covered a ton of ground here.
We really have. And if I could synthesize it all down for you, the listener, I say this. Remember, the NCLEX is testing your ability to prioritize.
It's always about what you do first.
Always. And in this setting, that means maintaining oxygenation and perfusion. When you see a bad pattern on the monitor, you go back to the basics. Stop the stressor, change position to improve blood flow, and give oxygen.
The second big skill is discrimination.
Can you reliably tell the difference? True labor from false labor, and early deceleration from a late one. It's about recognizing the pattern and knowing what it means.
Because if you understand the cause behind the pattern,
the intervention becomes obvious. It's not just memorization anymore. If you know late decelerations are caused by placental insufficiency, it makes perfect sense why your first move is to try and improve blood flow to that placenta.
the connection makes it intuitive.
It makes it intuitive, actionable, and it's what saves lives.
So here is our challenge to you, the listener. The next time you're studying FHR patterns, don't just memorize the lists of interventions. Think about something like an amnio infusion for cord compression. Really visualize that saline creating a cushion around the cord. See how that intervention directly addresses the specific physiological why. When you do that, the clinical how will be something you'll never forget.
That's the key. Keep integrating that assessment with the action is what makes a great nurse.
Until next time, keep diving deep into the knowledge.
Stay sharp.